It's so nice to be here today. I am a bit of a walker, so please just bear with me if I'm wandering in front of you. Hopefully the speakers will pick us up. Before I jump into the talk, I just want to discuss a couple of the mechanics so we're on the same page before I dig in. So this is for a job talk at the Rutgers Newark School of Public Affairs and Administration, or SPA as they call it. It'll be next Friday during an 1.5-hour long seminar. I've been instructed to take about 45 minutes, focused primarily on research, but with a brief section on my pedagogical approach and my courses that I could teach at Rutgers. It's an R2, it's a 2-2 teaching load, so they're interested in teaching in terms of whether or not they hire me. It's a position in health policy and health services, and I'll just note that I've kind of tailored this talk because only one other faculty member is an expert in health policy. The rest are more broadly focused on public management and public affairs with slightly different specific interests. So just so we all know before I jump.
In person or is it virtual?
It is in person.
Thank you.
Yes, thank you. Other questions before I get started? Oh, and the other thing is I will gladly take clarifying questions throughout, but I would prefer you hold substantive questions until the end. So with that, I'm very excited to share today my paper looking at the years before Medicare and how health insurance transitions during that period are going to shape health outcomes in later life. So briefly to introduce myself, I grew up in California in a tiny town called Ojai. I then moved to the Pacific Northwest where I pursued my undergraduate degrees in sociology and political science at Western Washington University in beautiful Bellingham. And then I moved from one coast all the way over to the other here in North Carolina, where I got my PhD in public policy at Duke University. I then moved just down the road here to Chapel Hill, where I'm now a postdoctoral trainee in the population science training program at the Carolina Population Center. Most of my research sits at the apex of 3 different themes, and I'm going to talk very briefly about each of those. The first is that my training is fundamentally interdisciplinary. I was trained in a public policy department, but most of my core courses were in sociology. I also had the opportunity to participate in the International Max Planck Program for Population Health and Data Science. And so I have robust demographic training, both from my PhD and from my time at the CPC. I also use a variety of different research methods. I think of myself as a mixed methods demographer, which is somewhat unique. Many demographers will focus on primarily quantitative approaches. And I love doing team-based research that is public-facing. So as a brief example, I'm currently engaged in a grant-funded project working on the impact of recent policy changes to Medicare Part D. And that work was presented to the Centers for Medicare and Medicaid over the summer to inform their decision-making. We also have an R&R that is about to be published at Health Affairs. So we're very excited. Look out for that in the next couple of weeks. And then finally, all of my research centers on structural inequality in some form or fashion. As a policy researcher, I always want my research to be practical and applicable. So how are these policy changes that I'm studying actually impacting people, and what can policymakers do to improve outcomes across different populations? So my dissertation research was really centered in these areas. I won't talk about it in depth. I'm happy to go more into it in the Q&A, but I will highlight that in a forthcoming paper, I look at Medicaid churn or insurance transitions, and that paper very directly informed the work that I'm going to present today. During my postdoctoral training, as Elizabeth said, I focused on LGBTQ+ populations, both mental and physical health, examining health insurance and different policies that might impact those populations. And I've also had the opportunity to work with the AdHealth epigenetic team, looking at epigenetic aging among midlife veterans. During my time at Duke and subsequently here at CPC, I've maintained a working relationship with the Durham VA. So this work directly complements the work that I've done with them, looking at aging among veterans of the first Gulf War. I will highlight very briefly that my ongoing research is still within those 3 broad themes, and it focuses on a lot of the same ideas that I've already talked about in the past couple minutes. And today's work, the years before Medicare, is really in this state-level policy variation, which we'll talk a lot more about in a few moments, and life expectancy. To give a brief overview of where we're going today, I'm going to start by discussing the project. I'll dig into the data, the results, some discussion, and then I'll go on to talk a little bit more about my future directions as a researcher here at Rutgers, and I'll talk about my pedagogical approach. So this project has two key aims. The first is to examine how often insurance transitions or insurance volatility is occurring in what I'm referring to as midlife. You might have a conception in your head of what midlife is. For today, let's just agree that midlife is ages 51 to 65. And I'm also going to document, based on those insurance transitions, how long these individuals are spending without insurance or with different forms of insurance. So the reason I'm focused on this midlife period is because, as many of us know, for decades, the US has been experiencing significant demographic change in the form of population aging. So if you look at this green line here, that's age 65, and we can see that the proportion of the population over 65 has been growing immensely, such that in 2020, roughly 56 million people were over 65, and those are individuals who are reliant on two of the US's largest social programs, Medicare and Social Security. Now, both of those programs were enacted decades ago when this distribution looked a whole lot different. So it's increasingly important to think about who are these older Americans, what will their needs be, because these programs are under significant strain already. What I propose is it's important to look at who is going to be in those next cohorts aging into Medicare. Who is aging? And in particular, I think that the health in those cohorts who are next to age into Medicare eligibility will inform the amount of strain on the Medicare program, right? Healthier individuals tend to have lower healthcare expenses, suggesting that Medicare expenses would be kept somewhat lower despite the population growth. So again, we're looking at this midlife period, roughly ages 51 to 65. The general theoretical model that I want you to have in your head and that I use for a lot of my research is the notion that is well proven in the literature that having health insurance or not having health insurance structures access to healthcare, which in turn contributes to ultimately health outcomes or health inequities that we can observe across populations. And in particular for today, I'm thinking about how health insurance during this sort of pre-Medicare period is going to shape health at age 65. So indeed, having health insurance is associated with greater healthcare, lower health risks, and again, through this theoretical model, I would expect better health at age 65. Lacking health insurance, on the other hand, is associated with the opposite, right? Less access to care, greater health risks, and potentially worse health in older adulthood. Now, it's important to think about who is getting insurance and where we get our insurance from. So most people in the US, roughly 66%, receive insurance that is private in some way. Most of those people, it's through either their employer or their spouse's employer. But nearly, oh, right, that it doesn't show up. Roughly 40% receive health insurance through either Medicare or Medicaid. And those are going to be the focus of the talk today. Now, I want to make sure that we're all clear on what Medicare and Medicaid are and what they do, because they are distinct programs that have really important implications for health. So they were both enacted at the same time, but they have very different structures. The first key difference is in how they are administered. Medicare is a federal program, meaning for the purposes of our talk today, it looks roughly the same in every state. We can talk in depth later about why that's not true. Medicaid, on the other hand, is a federal-state partnership, and states have a huge amount of leverage to design the program in terms of how they see fit for their population. They also vary in terms of who is eligible for these programs, and I won't go into detail, but for today, we'll just think Medicare is primarily for adults age 65 or older, whereas Medicaid is primarily for low-income children, families, and in some states, childless adults. This federal-state partnership is really important if we're thinking about state-level differences in health. So Medicaid policy is structured in such a way that individual states receive differential funding for Medicaid. So for example, in New Jersey, the federal government funds roughly half of all Medicaid costs. In North Carolina, where we are today, the federal government funds 65% of Medicaid costs. So some states receive greater financial remuneration from the federal government than others. The second kind of key state level variation is there's different eligibility thresholds. This has been exacerbated by the Affordable Care Act, which enabled states to elect to expand Medicaid to include childless adults. So some states have this, some states do not. And then because it's administered by states, things like the processing time, how long it takes to enroll, the ease of getting access, your benefits can all vary across states. All of this produces geographic inequities that have been well documented in terms of what Medicaid beneficiaries actually experience when they're trying to get or use benefits. So what I'm going to refer to as Medicaid generosity, sort of the robustness of the program, who's covered, what's covered, is going to vary across US states because of these factors. And I will argue that that's going to structure access to health insurance. Now, two key policies are really going to be important as we go on. The first I've already mentioned is the Affordable Care Act. That's going to create variation in terms of state-level Medicaid programs that was not as present before. And the second is the Families First Coronavirus Response Act. I used to have that defined. I will make sure to add that back in. So there are two key provisions. The one we'll discuss today in the context of insurance before age 65 is the continuous coverage mandate. This was a mandate implemented by the, in September of 2020, to ensure that across states, particularly non-expansion states, anyone who was enrolled in Medicaid, they were required to remain enrolled per the state until the end of the emergency period. So if I have Medicaid in September of 2020, I have a low income, I'm eligible, I'm not going to lose my benefits until the very end of the emergency period. So this prevented something that's known in the literature as Medicaid churn, or losing and gaining insurance benefits. This had already been lower in expansion states, and it declined rapidly due to the Families First Coronavirus Response Act. So the first thing that I'll work on that. The first thing that I'm looking at in this paper is to describe insurance volatility. Part of that is that Medicaid insurance churn, but it's also other forms of insurance change. The reasons we might care about disrupted coverage, Medicaid churn, is that losing access to health insurance is associated with a variety of negative health outcomes, from lacking a source of care to greater mortality risk. I propose that all of these things, when experienced between ages 51 and 65, contribute to worse health at age 65. So understanding how often this insurance volatility is occurring can give us a better sense of what the Medicare population will look like in the next coming years. I will just briefly preview that another key policy to consider here is the recent Budget Reconciliation Act, previously known as the One Big Beautiful Bill Act, that had specific provisions related to Medicaid that largely make accessing Medicaid more difficult. And indeed, preliminary research has suggested that roughly 12 million people will lose coverage as a result of this bill, about 8 million from these changes to Medicaid alone. And it's likely that this is going to increase insurance churn, which I've just described as being a not so good thing. So this access to health insurance, healthcare, and our health is really shaped by the state that we live in. And so if we want to get an understanding of the state level variation and its impact on health inequities, we have to take this sort of broader contextual approach. And what I will do then is document the time that adults can expect to live with these different coverage. I just highlight here that life expectancy already varies across states. And so we might expect there to be a differential impact of, for example, Medicaid expansion on life expectancy with these pre-existing disparities. So for example, here in North Carolina, a woman aged 25 can expect to live another 54 years, whereas in New Jersey, that same woman could expect to live almost 56 years. So these are pretty distinct disparities that we can see across the life course. So these two aims inform two research questions that I will answer in the coming slides, looking at the frequencies of these insurance transitions and the expectancies, how long people can expect to live in these insurance states. For both research questions, I'm going to interrogate whether they vary across state policy contexts and examine whether they vary across sociodemographic characteristics. To do so, I primarily focus on the Health and Retirement Survey, or the HRS, which is a longitudinal survey that is representative of adults aged 50 and older in the US. It's been conducted since 1992, and every 6 years they replenish their sample with younger adults, so those who are closer to age 50, to ensure that their sample remains representative of the current population over 65. I have gained access to restricted geographic information that enables me to access the respondent's state of residence at each wave. And ultimately, I use the RAND HRS longitudinal file, which is a compiled data file that enables researchers across disciplines to use the same data set to ensure there's no variation in terms of how we merge these many, many years of data. And ultimately, I have about 42,000 individuals who are matched to that geographic information. I will note that the cross-wave geographic information only goes through 2020, and that limits some of my other data, which we'll talk about in a moment. So my sample ultimately is from years 2000 to 2020. There are some data inconsistencies prior to that year. This is fairly common in demographic research. And I look at adults aged 51 to 64.99, right? So right before they're eligible for Medicare via their age. Ultimately, I have a sample of about 20,000 unique individuals. You'll notice that's a huge drop from 42,000. The primary reason is that only about 23,000 individuals are between the ages of 51 and 64.99. So really my sample being restricted in these ways, it's not a huge reduction as it might have appeared. So I then link this with data that's basically just an indicator for whether a state expanded Medicaid in a given year. And so any of these darker blue values will be captured in the data. So any expansion before 2020 will be available. I then link this with a novel data source that captures Medicaid generosity, that kind of concept that I hinted at a little while ago. This data is constructed by researchers at SUNY Albany, and it's publicly available upon request. I highly recommend using it. It's fascinating. And I will just highlight that I'm the first researcher to link this data with the HRS, giving me the ability to examine how their measure of Medicaid generosity impacts the HRS population. So how do I actually measure any of those things that I've mentioned? Well, Medicaid expansion is fairly simple, just a dichotomous indicator, and it's equal to 0 in all states before 2014, because I'm only looking at ACA expansions. The Medicaid Generosity Index is constructed based on 4 categories, each of which range from 0 to 100, and then they're averaged across those 4. It's based on the income limits of a Medicaid program, the application or enrollment process, and immigrant eligibility, alongside the actual benefits of coverage. And you can see there that higher scores reflect more generous programs. I have dichotomized this to a simple 0-1 variable indicating whether it's the 75th, yes or no, or below the 25th percentile, yes or no. And I will note that these results are robust to alternate specifications of that dichotomization. I'll just highlight here that I never include both in the same model due to issues of collinearity, because although Medicaid expansion does not factor into the Medicaid Generosity Index, they are highly correlated and related to one another. And you'll see that those Medicaid generosity percentiles, the 75th and the 25th, both increase over time, but we don't really see any rapid changes around the Affordable Care Act, which I think indicates that Medicaid expansion and Medicaid generosity are capturing slightly different elements of Medicaid program at the state level. At every single wave, the HRS collects information from respondents about their insurance coverage, and then they also keep records of when individuals die. And so based on those data, I will place people into one of 5 groups, right? Do you have no insurance, private coverage, Medicaid, some other form of public insurance, which is primarily Medicare or a VA or TRICARE plan, or have you died? And I will do that at every single wave. Finally, I include a battery of common sociodemographic characteristics. I'll just highlight here that I do also examine retirement status, because roughly 20% of the sample are completely retired. So these are people who are under 65, but report being retired. And given that employment is so closely tied to insurance, this is an important factor for this population. To answer my research questions, I use multi-state life tables. Now, when I say state, I don't actually mean a US state. It means something different. So to make it clear, rather than say state for a multi-state life table, I'm going to refer to it as a multi-status life table, and that will become much clearer in the following slides. So to construct a multi-status life table, I'm about to show y'all a figure that's going to be a little bit busy. We start with a status diagram. Now, I'm going to walk you through what each of the things in this diagram are. The first thing you need when you're estimating a multi-status life table is transition probabilities. All of the P's on this diagram are transition probabilities. So P12, for example, is the probability of transitioning from having no insurance to having private insurance. And then based on those transition probabilities, I will estimate how long people can expect to spend in each status or insurance state. And across all models, I will include the collection of covariates. In particular, today I'm using a non-parametric bootstrap approach to this multi-status life table, which first requires estimating those age-specific transition probabilities from a multinomial logistic regression. Ultimately, what I end up with is a variety of matrices for each age that document those same probabilities I showed in that figure for if you start with insurance at time t plus 2, the next observation, because HRS is collected every 2 years, what's the probability you remain uninsured, transition to private insurance, etc. So those are the outcomes of that first model. I'm going to do that 1,000 times. Then I will estimate a population-based radix. So the radix is effectively the initial population for whom you will apply those transitions to see at the end of the period how many people are in each state. So I calculate this for ages 51 to 52.99, which is that first 2-year age cohort. And most people have private insurance at this time, but we see there's a distribution across the other forms of insurance. Based on those 2 things, the age-specific transition probabilities and the radix population, I then estimate status expectancies by multiplying those together. So it's a fairly simple issue of matrix algebra. You multiply your radix for an age-specific, for an age group by the insurance, by the transition probabilities for that age. And you repeat that at every age, and we end up doing that 1,000 times. So once I've summarized those results, I then go all the way back up to the top and I do it again for a different covariate profile. So for example, if I'm interested in Medicaid expansion versus non-expansion states, I will go all the way back up and say, okay, what about for people in expansion states only? And do this all again to compare to non-expansion states. The covariate profiles that I'll be focusing on in my discussion today are those Medicaid expansion characteristics, Medicaid generosity characteristics, and race. The other results I'm happy to discuss in the Q&A, but for the interest of kind of focusing our discussion, I'll keep it with these three. I'll also briefly discuss some age results. So the general form of the results from a multi-status life table are an estimate of total life expectancy between the ages that I've assigned, and it's going to be a summative measure of the years expected in each of these statuses, insurance types, that I've identified. Now, I will note that roughly 2% of the sample dies. So although total life expectancy, if you did that math really quickly, the total could be 13.99 years. All of the estimates will be a little bit shorter than that because we have some mortality that occurs. The sample is primarily female. We have a fairly good distribution across racial and ethnic categories. And as I said, 21% are fully retired. I'll note that Medicaid generosity is correlated, as I said, with Medicaid expansion status. So it tends to be the mean is lower in never expanding states and increases as expansion does. But again, I think we're capturing something slightly different with these two measures, given that there's no distinct differences across Medicaid expansion status in terms of the mean of Medicaid generosity. So now I will discuss some of those key results. As a reminder, my first research question is to get an understanding of how frequent these transitions are across policy context, and in this case, across some sociodemographic characteristics. So this graph is going to show on the x-axis the proportion of people with consistent insurance coverage. That means at time t, they had no insurance, and at time t plus 2, they still had no insurance. Private insurance, private insurance. So these are our, we can think of them as the non-transitioning people, right? They remain in a single insurance status. In the sample overall, roughly 80% of people don't experience an insurance transition from one wave to the next. This is much lower in post-expansion states compared to pre or never expanding states. So the flip side of this would be that you can think that roughly a quarter of the people in post-expansion states do transition in insurance status between one wave and the next. I don't observe any differences across Medicaid generosity. This graph is showing the same thing, the proportion changing, but on the y-axis is the starting insurance status. So did you start without insurance at time 1, private insurance, or Medicaid? And the colors are the exact same as they were on the previous graph. I will highlight here that again we see, or that although we saw that insurance transitions were more common in post-expansion rather than non-expansion states, we also see that most of the transitions that are occurring in post-expansion or high generosity states are from uninsurance. So that basically means you're going from an uninsured status to having some form of insurance at the next observation. The second thing I'll highlight here is that in non-expanding states, the probability of remaining uninsured is higher, or the likelihood of changing from uninsured is lower, and the probability of changing from Medicaid is higher. This is looking at racial and ethnic disparities, and I'll just note that non-Hispanic whites have the highest coverage consistency during this period. And Medicaid churn, that is losing Medicaid coverage, right? So transitioning off of Medicaid coverage is much higher among racial or ethnic minorities than it is for non-Hispanic whites. All right, for my second research question, I have to understand how long people are actually living in each of these states. The first thing I need to know is how much they're dying, right? So I'll highlight just a couple features here, which is that as we might expect, the probability of death is going to vary based on those policy characteristics. So in a never expanding state, the probability of death is higher than in a Medicaid expansion state. We also see that the probability of death increases with age, such that our older cohort is much more likely to die than either of the younger two. And we see a racial patterning that would be roughly expected for this age group, where non-Hispanic Black individuals have the greatest mortality, followed by non-Hispanic whites, with Hispanics having the lowest predicted mortality. So now I'm using those probabilities that I showed you, that probability of death, to estimate that overall, how long can people actually live between these periods? So overall, the life expectancy that we observe in this population is 13.74 years. Again, that's shorter than the theoretical maximum of 13.99, documenting that some people do die, shortening that total life expectancy. Now, that life expectancy varies across policy context, again, in a predictable way. So in post-expansion states, the expected total life expectancy is quite close to that theoretical maximum, which is very reasonable given that the probability of death in post-expansion states was the lowest of all of our probabilities of dying. And ultimately that equates to about 0.15 years longer life expectancy during this period, which is only about 14 years in expansion states relative to non-expansion states. Okay, now this graph is showing something slightly different. On the bottom, we have the total years at age 51, and you can see 14 or 13.99 is that theoretical maximum. And it's split into the number of years that someone can expect to live uninsured, with private coverage, with Medicaid, or some other coverage. I will draw your attention to the fact that compared to non-expansion states, post-expansion state residents spend one less year uninsured during this period compared to the folks in never expanding states. Similarly, they spend roughly 1.5 more years with Medicaid coverage than their peers in non-expansion states. I will highlight that although I didn't observe differences for Medicaid generosity in terms of the total life expectancy, I do observe differences in terms of the time spent with different insurance statuses, such that in a higher generosity context, someone can expect to spend roughly half a year less uninsured and a half a year more covered by Medicaid. Finally, I'll walk through my results across racial and ethnic groups. So total life expectancy, as would be expected based on mortality, is greatest for Hispanic individuals. And again, we see these pretty significant patterning of insurance and uninsurance across race. So Hispanic individuals spend the greatest amount of time uninsured. It equates to almost 2 years more than non-Hispanic whites and about 1 year more than non-Hispanic Blacks. Both non-Hispanic Blacks and Hispanics can expect to spend roughly 2 years covered by Medicaid, which is compared to less than a year for non-Hispanic whites, who also spend the most time with private coverage. So in sum, I find that insurance churn, that changing those transitions, is most common in Medicaid expansion states. I don't actually talk about the age thing, I should take that out, and among racial minority populations. Medicaid expansion is associated with 1 less year uninsured during this pre-Medicare period. High Medicaid generosity is associated with a half a year less time uninsured, and racially minoritized individuals are spending the most years both uninsured or covered by Medicaid. So now I'm going to walk through some policy implications and discuss the next steps. So my 2 aims were to describe these insurance transitions and then document those status expectancies in this pre-Medicare period. And I will remind y'all that this is driven by the fact that the Medicare population has been and will continue to increase for decades to come as the population over age 65 grows. So in 2020, roughly 17% of all people in the US were over age 65. By 2040, that'll be more than 22%. So Medicare costs, as this population grows, are inevitably going to increase. More people equals higher cost. But those costs, it did 2 things at once, there we go. Those costs will depend not only on enrollment, they'll also depend on the health of individuals once they enroll in Medicare. And as I hope I have evidence today, the years before Medicare shape your health once you enroll in Medicare. And this looks different across US states. In particular, insurance churn, while it's occurring more frequently in Medicaid expansion states, there's not as much uninsurance in those states. So I'm not sure that people are really experiencing those disruptions that are known to be detrimental for health. So it's unclear whether this would be associated with positive or negative health at age 55, 65. I would argue that because of this low uninsurance, Medicaid expansion states may ultimately have healthier Medicare populations as the next cohorts age into eligibility due to these low rates of uninsurance. I would also argue that due to uninsurance or insurance being high, along with uninsurance being high, that racial minorities are experiencing many insurance disruptions, suggesting worse health at age 65, such that the Medicare population overall will reflect persistent and potentially worsened racialized health inequities as the next cohorts age into eligibility. And the next cohorts of Medicare enrollees will be more racially and ethnically diverse, such that these disparities that we observe in insurance status, producing health disparities, may be exaggerated. So really, I think this has significant implications for the future of Medicare. In the context of current policy provisions, which are likely to increase churn experienced in these populations, increase uninsurance, and likely worsen health for the next cohorts aging into eligibility. Meaning that Medicare costs, which were likely to increase, are going to increase more rapidly than would be expected based on population aging alone. And they may in fact be even exacerbated by the greater health burdens in incoming cohorts. So I return to the Budget Reconciliation Act, which is effectively an attempt to dismantle Medicaid expansion and make enrolling in Medicaid and maintaining Medicaid coverage more difficult for the people who rely on this coverage. And as I mentioned, this will produce huge rates of uninsurance and insurance churn. So I argue that specifically the Budget Reconciliation Act of 2025 is going to exacerbate state-level health disparities and, per the results of this study, exacerbate increasing Medicare costs through those mechanisms of increasing insurance churn and uninsurance. And indeed, we know that the changes to uninsurance are likely to be patterned across states, potentially producing additional state-level variation. What I hope you take away is that preventing insurance churn and uninsurance in these years before Medicare, as the talk is titled, has the potential, to decrease Medicare costs, or at least rein in Medicare costs, but perhaps more importantly, to improve population health outcomes for decades to come. I'll briefly touch on some of the broader significance of this work. So this is one of the first studies to use that Medicaid Generosity Index. The researchers at SUNY Albany made it available in 2022, and it has been in very few publications. So there's still a lot that we don't know about what that measure is capturing and which populations it might be most applicable to. So for example, in my other work looking at age 65 plus, that Medicaid Generosity Index is not really picking up any meaningful variation in Medicaid for adults over 65, so it might not be the most appropriate measure for that population. Second, this is one of the first papers that I know of to assess the relationship between policy context and insurance churn, and to compare both across US states and across populations. It's also highly relevant in the current policy context. Research would not be research without limitations, and this work has a few significant limitations. The primary one is that the HRS is conducted every 2 years. Insurance churn can occur as rapidly as monthly. Medicaid disenrollment occurs every single month, primarily due to administrative errors rather than individuals electing to disenroll. So it's quite likely that I'm underestimating the churn or transitions that are happening within this population. I argue that the HRS is an excellent sort of first look at this because it's a longitudinal study. I'm able to follow the same people over time, and I have robust information about their context and the state in which they live. But it is, of course, imperfect. The second is that I dichotomize a continuous measure, which inevitably reduces the amount of variation that exists within that measure. So potentially I'm ignoring some variation and introducing bias. And in fact, I have other papers where I do use it as a continuous measure, and that's something I'll speak about in a moment. Finally, the data currently are only available through 2020. So although the Family First Coronavirus Response Act was hugely important in reducing churn, I can't actually capture whether or not that occurred in this population. So to address some of those, the next steps, this is a paper that is currently under review. So the next steps are to include Medicaid generosity as a continuous measure and to request more recent data. I'll briefly talk about my ongoing and future research, and I'll probably skip the pedagogical stuff for today since I'm more curious about this stuff. So as I said at the beginning, my research follows a variety of themes related to population health and demography. And so in particular, I want to highlight that my future work is going to focus on state-level policy variation, life expectancy, and health equity. So one of the key ways that I'm planning to do this is to examine not only variation in life expectancy, which I showed you at the beginning, varies across states, but also to examine the variation in healthy life expectancy that occurs across states. So for example, in New Jersey, a woman aged 25 can expect to live about 2.5 more years in good health than a peer here in North Carolina. So what I want to do is examine that variation and see how that varies in older adulthood across levels of independence or dependence and across policy contexts. So in particular, this is motivated by the idea that the population is aging, and the population has rapidly increasing healthcare needs, and there's a greater diversity of care types that individuals are seeking, such as skilled nursing, assisted living, in-home care, and more. I also think it's really important that we define health as a multidimensional and time and context-specific measure that might not be captured by traditional measures of health that we commonly use in studies of demography of health and aging. And finally, per much of my research, I really want to understand how policy, and I'll focus on Medicaid specifically, contributes to unequal health burdens experienced in late life. Oh, okay, we're doing that slowly now. And I'll highlight that New Jersey could be an interesting place to begin this research because roughly 22% of all Medicaid beneficiaries in New Jersey are age 65 plus. So this creates an interesting population of people who are low income and of a higher age who might require various kinds of care. I'm not going to talk about that right now. So the planned project, this was part of a career development application that I submitted to the NIH, is going to be an interdisciplinary and mixed methods project where I will conduct interviews to examine how we define health across time and context. And it will be highly community engaged, as many of my other projects. For example, here in Newark, there are about 4 continuous care communities within a 30-minute drive, and those would be a great place for me to begin conducting interviews with older adults receiving some form of care. And again, it will be a structural investigation based on variation in Medicaid policy. And with that, I'll close. I'll just briefly say for my pedagogical approach, I'm going to talk about my training that I've had or will have, and then I'm going to talk about 3 things, which is how I approach teaching very briefly, the courses I could teach, acknowledgements, and then I will say thank you. So thank you. And I welcome comments or feedback, or questions or feedback, whichever is, yeah.
Great presentation. I came in a little late, so I gathered it's a job talk.
Yes.
Very exciting. Your slides are very dynamic, and it's one of the more kind of engaging presentations. I felt like I was with you the whole time, which was definitely not the case for a lot of presentations. So well done on that. I had 2 kind of like substantive questions, and this is not my field at all, so let's take them as you will. One was the way you were talking about insurance churn, and kind of the big picture is sort of presenting it as a negative thing. But when you were presenting your results, I was realizing, well, actually, it could be positive if you have more expansion and people are moving from uninsurance into an insured situation. So why focus on insurance churn rather than loss of coverage as the main thing you're looking at? And then my second question was around the Hispanic population, because I think towards the end of your findings, it was showing that they're the least likely to actually have coverage and yet the longest lifespan. So they seem to be going against your fundamental theoretical modeling. And maybe you should like comment on it, or like, is that an immigrant health effect, or how do you make sense of that?
So thank you. Those are both great questions. I'll answer the first one first. So I think focusing on insurance churn is relevant in large part because different forms of insurance produce kind of different outcomes. So someone who has Medicaid likely has fewer options in terms of their healthcare access than someone who has private employer-based insurance. And also, I think losing coverage is important, and that's definitely part of the story. But that's why I look both at the transitions and the time. So in expansion states where someone is experiencing greater churn, we see that much of that is from uninsurance. And so I think by looking at both together, you can get a fuller picture of not just the loss of coverage, but where coverage change is happening. Is that helpful?
Yeah, I have a hard time disentangling whether it's good or bad. And like
it is very hard to disentangle whether it's good or bad. And I think Medicaid expansion states create an interesting dilemma in that we would think of insurance churn generally as bad. Most of the literature says changing insurance is not good. It disrupts your usual source of care. You're less likely to get preventative services. But if a lot of that churn is occurring because people are gaining insurance, right? Because churn refers to both. So maybe it's an issue of thinking through, is it a loss of coverage or a gain of coverage, kind of as you said in your question. And I'm able to look at both. And so I think that's a strength of this approach. To your second question, I do think it's a potentially a healthy immigrant effect, especially given the age of these populations. So Hispanics who are a little bit older were likely in the US for longer. And so although there is the potential for kind of acculturation and the, the decline of health due to the presence in the US racial hierarchy, I do think that's part of what we're observing there. I think it's also a unique age period where we know from recent demographic research that a lot of the mortality that's occurring in midlife is driven by non-Hispanic whites. And so it's potential that there's just lower mortality in that population currently.
Can you tell if they're foreign born in the data?
I can. I could look at that. I should get out of thing. I got you. Other questions, comments?
Yeah, so this is great, by the way. And again, also not my area, so you can just tell me to shut up if this like isn't something you want to go down. But I do know in HRS, there's tons of information about their health status. So, and kind of your sort of theoretical model is really the foundation of that is the health status of these individuals. And have you thought about looking at the health status broadly? I know you talked sort of at the end about redefining like what does healthy aging look like, but you do have some information around kind of like where they're starting and if that's correlated, like their health status, and if that's correlated with where they're moving, transitioning, and then obviously geographically, that's going to tell you a little bit of information kind of about that population as well.
Yeah, so that's a great question and a great point. So health status is highly predictive of having insurance, but it's also highly predictive. It's quite correlated with Medicaid enrollment, especially after age 65.
Right.
So that is something, I don't think I mentioned it at all, but I do control for in the models just using, I should make note of that and say what, but I'm not explicitly looking at like how much it contributes to these transitions.
Right.
That's absolutely something I could do in a next step and think through how, functional limitations, for example, impact one's insurance transitions during this period, as well as because it's so highly linked with health is so highly linked with mortality.
And again, I don't know anything about like, a ton about insurance policy, but I do know, right, like pre-existing conditions and those types of things that sort of bar individuals that maybe are trying to transition to an insured state, but it can't because of some reason.
There's a lot that goes into that. Yeah, and so it's kind of beyond the scope of this project.
Yeah,
but
yeah, yeah,
definitely
for
something
sure.
that I will incorporate. Yeah. Yes,
I don't know anything about the topic either.
great.
But I love that you're bringing our state of New Jersey into your. I think that's really important and that's good. I did wonder though, when you had your like different things you were gonna do, how you were gonna be able to talk about structural variation if you're only focusing on New Jersey. So you may want to reflect on how that would happen or what you might compare it to.
That is a great question. You're talking specifically about sort of the future directions.
Sure.
Yes. So what I should have said, and thank you again, is so I plan on doing qualitative work that will be centralized in one state where I compare rural versus urban kind of older adults to get an understanding of how health is shaped by our sort of context, trying to kind of proxy socioeconomic status, and then our health status, so across different levels of care. I'm going to couple that with a national quantitative study using the HRS along with Medicare claims to examine transitions in in care types and how those are related to both our existing measures of health and potentially, if possible, other measures of health to estimate disparities in healthy life expectancy across these different contexts.
Okay, so I also wondered why you were focusing on the qualitative part only on the older folks.
So it's
I mean-
all focused on older adults, and I should
But
clarify.
I wasn't sure why, because you're talking a lot about your 51
Yeah.
to whatever, and they have ways of defining health differently. And
Yes.
I was wondering why you wouldn't include them.
That's a great question. So I will first just offer the sort of real answer, which is the scope of the project had to be sort of narrow. So I'm focused on adults age 65 plus to address sort of contemporary issues with aging. But my plan after that project is to then do an R01 proposal where I would examine these variations across the entire life course. So focus perhaps on middle age, but with some inclusion of young adults, probably not children because of IRB and other issues with that. But yes, thank you.
Okay, another person, this is not my area at all. I was just stuck. It's the complexity. It's going to be a sort of weird question.
Great.
So I am not proposing that we shouldn't be expanding Medicaid and making people healthier. But you talk about then looking at healthy life expectancy, but in terms of Medicaid costs, unhealthy life expectancy matters as well. So if you make people healthier and they live longer, they spend more time in Medicare and potentially more time at the end of life in unhealthy care. So when you're arguing that the costs will go down, is that accounting for these more other complex dynamics that might play in?
So that's a great question. And there are so many different ways to think about sort of the compression of healthy life expectancy that is currently accompanying the extension of life expectancy, right? So you're totally right. People are living longer, but right now what we're finding is they're living they had been living a compressed period with an unhealthy status, which is now growing. So people are spending more time in an unhealthy status than they were before. And that is contributing to increasing costs. So if we can return to a compression of unhealthy life expectancy, yes, there is significant costs associated with, deteriorating health. But if we can make that shorter and ensure that the other periods of life are healthier, it's likely that would decrease costs. Of course, all of these are happening in parallel. And so it's very hard to disentangle exactly what that relationship would look like. But you bring up a really good point that, increasing health is not like expanding Medicaid to improve health will not directly decrease Medicare costs. I think my primary argument is that for the next cohorts, they won't contribute as much to that increasing costs if they are healthier than they would if they were unhealthier. Does that answer your question?
Yeah, and I think it's complicated. I mean, because the cheapest would be if everybody died at 64.
Well, right. Exactly.
That's not what we're aiming for.
Life is related to this. Life expectancy is about transition between states, and it's irreversible. Healthy life expectancy, you can go back and forth. So does your analysis take into account that you can shift back and forth between health and is the pattern of shifting changing, and is it relevant to what you're talking about?
So in this study, I'm not actually looking at healthy or unhealthy, right? I'm looking at those insurance statuses, and people can absolutely go back and forth and between. The only possible transitions are from death to any of the other states, right? We cannot come back to life. And so in models examining healthy life expectancy, such as those that I will implement in this next project, yes, I will absolutely account for transitions that can occur from health to unhealthy. I also plan on, again, thinking about health as a more multidimensional measure to get an understanding of, for example, does subjective well-being, sort of how we think we're doing, does that kind of impact how long we're living healthy in a different way than just something like activities of daily living, right? How restrained is your limit, or how restrained is your list? So I really want to compare across measures to get an understanding of how different components of health shape the years that we are spending in good or bad health. Did that answer your question? I feel like I went on. Okay, great.
Just going back a couple steps to Carrie Lynn's question, but in terms of the churn, is there, and I know this is a longitudinal because you had, what was it, 63,000 person observations. Is there a marker of how much people go back and forth, as well as just the transition from the last period to the current one? Excuse me, the current one.
I have looked at that. It's been a long time, so I should go back and check. I think it's in the paper. I will check. You're thinking like how often people
Like how much
Number
churn?
of transitions.
Oh, number of transitions. Okay, yes, I have definitely looked at that. And I don't remember.
It might be nice as a supplemental.
Yeah.
slide.
I
Okay,
agree.
yes.
I just have a quick question. Do you control for, I didn't see it up there, but maybe you do it in the background anyway. Marital status, because that's such a key way to gain or lose is by getting divorced or widowed or getting married.
So that is something that I have looked at. I would have to see if I ended up specifying that in the main model, but that's definitely something I have looked at because it is highly relevant for insurance. I will double check.
And I guess it's also relevant for life expectancy.
Yeah, that's true.
too, so.
Yeah.
Yeah. And wasn't your population like more? And
Yeah, about 60%. Yeah.
And they don't ask in the 2-year window, did you have insurance, like, do you have an insurance history over the 2 years?
They do not. No. So yeah, unfortunately, I only have those 2-year gaps. Or in some cases, it's a little bit shorter depending on like if, yeah, but yeah, so I cannot capture those things. But in the project that I'm proposing to do, I would apply for and hopefully link this data with Medicare and Medicaid claims. And I'm not sure exactly what the structure of that data set will look like, but I'm curious if it will be easier to examine kind of those more minute, specifically in the Medicaid cases. In terms of uninsurance, it's still kind of harder to tell, but yeah. Yes.
This was such a great presentation, and you presented so well,
Yeah.
super engaged. You mentioned that you're going to have at least one health policy person in the crowd. I study health policy.
Excellent.
So I
Yeah,
can tell you that talking about cost containment and making claims about cost containment is a very quick way to get them riled up. And so I would encourage you to have a reference in your back pocket, because it will most likely ask about, can you show empirical evidence that we can contain costs by making people healthy? Because I can say with some amount of confidence that it's unlikely you'll find United States studies that have shown that. So maybe you can look at other countries, just like have a reference in your back pocket because they will ask you that.
Yes.
And so when you say, oh, we can potentially reduce costs, be like, X has shown this in Canada or something like that, just to preemptively avoid critique from that health code.
Thank you for that. And I do actually have several references, which is there's quite a few studies looking at health upon enrolling in Medicare at age 65. And we do find that people who were uninsured before they enroll have higher costs upon enrolling, and people who have worse health upon enrolling have higher costs. So I need to remember exactly who wrote those, and I think they're both old. They're from like 2008, but nonetheless, those would be good to have in my back pocket. So thank you for that.